Hi, everyone, and welcome to tonight's Advanced Practice Provider webinar. I am Jenny Ledbetter, and I will serve as the moderator tonight. I am a certified adult clinical nurse specialist and the bariatrics program coordinator at St. Francis Hospital in Charleston, South Carolina. And I'm also a member of the Integrated Health Advanced Practice Provider Committee. I would like to welcome you tonight. We are thrilled to have you here. And you get the privilege of hearing my colleague, Patrick Walker, who will talk tonight on direct oral anticoagulants, or DOACs. I hope you all have paid notice to the slide that is being shared about the Advanced Practice Provider Assessment-Based Certificate, or ABC, course that we will have at the ASMBS annual meeting in Las Vegas this June. Our dates are the 25th through the 27th. It was created by APPs, and we will kind of run that event. So some of you may have participated in that last year, and we are certainly looking for others to participate this year. Also want to put in just a plug. If you are not a member of ASMBS, I would highly encourage your membership. It is a fabulous organization for networking, education. So a little plug to join ASMBS if you have not yet. Another upcoming event that I wanted to mention briefly is an IH networking event that is actually next Tuesday, January the 24th, from 7 to 8 Eastern Standard Time. This is for bariatric program coordinators, APPs, nurses, dietitians. So we really are hoping to have a good participation in that as well. And there is pre-registration that is required on the ASMBS website. Just a reminder to please mute yourselves tonight. If you do have questions, you can put those in the chat. I'm going to try my best to monitor those with some help from some of my colleagues. And we will, or there is a message in the chat about getting CME. We will have a link for that available after the presentation, and we will have a follow-up email. And finally, I think before I introduce our speaker, the networking session that we will have after the presentation will be for the APPs attending tonight, and Patrick will then excuse himself. So we will have a Q&A with him before he bows out. So now it is my pleasure to introduce Patrick Walker. He is a board-certified critical care pharmacist who received his doctorate of pharmacy from the University of Georgia. We already had a little go dogs. He completed postgraduate training in critical care pharmacy at Greenville Health System, which is now Prisma Health Upstate. He currently practices as a pharmacy clinical specialist in one of the med-surg ICUs within the Roper St. Francis Healthcare System in Charleston, South Carolina. He also serves as a pharmacy representative for a number of the multidisciplinary perioperative committees throughout our system, and I have the privilege of working with him as part of our bariatric and metabolic interdisciplinary committee at Bon Secours St. Francis Hospital. So welcome to Patrick.
Thank you very much for that introduction, Jenny. As mentioned, Patrick Walker here. I will once again say go dogs, and also share a little bit of bad news for myself today that I've already shared with the APP subcommittee. I unfortunately had my internet go out just before this meeting and had to rush to the hospital. So just a little bit of negativity, but the rest of this presentation hopefully will be very uplifting for us all. So jumping right into it, I have nothing to disclose other than my disdain for hot wire connections. In regards to what we'll be covering today, we'll be reviewing our oral anticoagulants as well as guideline recommendations for atrial fibrillation and VTE treatment. We'll also be assessing the literature regarding direct oral anticoagulants, particularly a focus in our morbidly obese population, as well as discussing perioperative management of all of our oral anticoagulants with a focus in high-risk bleed procedures, considering the focus being in bariatric surgery. We'll then go into determining the impact of bariatric surgery on the use of our oral anticoagulants, as well as evaluate current guideline recommendations and strategies for managing our DOACs in the post-bariatric subpopulation. Going to caveat that we're not going to go too deep into pharmacology. As a pharmacist, I know that can sometimes be very dull. But I do find that it is very helpful when talking about anticoagulants to first get an idea of where exactly they enact their effects. So always great to start with the clotting cascade. So on the left, we have our intrinsic pathway. On the right, the extrinsic pathway. So going down from factor 7 and factors 12 all the way to fibrinogen, working with thrombin to form a fibrin clot. So looking at our parental anticoagulants first, we'll start with the unfractionated heparin, which works on factors 9, factors 10, and factors 2, also known as thrombin by its activity on antithrombin 3. Low molecular weight heparin primarily enacts its effects on factor 10, but also works on factor 2, also known as thrombin again. And then when we jump into our oral anticoagulants, we'll see that we work on factors 2, 7, 9, and 10 with warfarin. All vitamin K dependent factors, hence why warfarin is a vitamin K antagonist. And then when we start talking about the focus of this presentation, our direct oral anticoagulants, also previously known as novel oral anticoagulants or target-specific oral anticoagulants. These agents are working specifically on one factor. So in the case of our factor 10A inhibitors, they're going to work on factor 10. This can include apixaban, rivaroxaban, edoxaban, and petrixaban. We're going to focus on these first 3 factor 10A inhibitors as petrixaban is only utilized, or at least I should say FDA approved, for DVT and PE prevention in the post-op setting. And then we have direct thrombin inhibitor, dabigatran, or a specific factor 2 inhibitor. If we were to compare our oral anticoagulants, or at least our direct oral anticoagulants to warfarin, we'll see that there are some very noticeable differences. So drawing your attention to the onset row, we see that all of our 4 direct oral anticoagulants are very rapid in terms of enacting their effects, reaching peak activity levels within hours, versus warfarin can take several days. Hence why whenever we initiate someone on warfarin, whether that's for AFib or for a mechanical valve, these agents are going to require a parenteral bridge, so with unfractionated heparin or low molecular weight heparin until we achieve a therapeutic level. That then throws us down to a benefit of warfarin in comparison to our direct oral anticoagulants, and that warfarin has the capability for monitoring, and that we have a validated tool, the international normalized ratio, to determine if a patient is actually sitting within a therapeutic range on their current drug regimen. Unfortunately, with our DOACs, we have assays that are affected by the effects of dabigatran, rivaroxaban, apixaban, and edoxaban, such as thrombin elastin time or anti-10A activity. However, none of these are validated in terms of establishing a therapeutic range. So that can sometimes be difficult in managing patients, particularly with drug-to-drug interactions. Although warfarin tends to have a much longer list of both drug and food interactions, we do have that benefit of being able to adjust the dose accordingly, depending on the degree of effect. For our DOACs, though, we're kind of left with a situation of completely avoiding using these agents, or just carrying that potential risk that the therapy is either going to be less effective or potentially predispose the patient to a higher risk of bleeding. That being said, we sometimes elect to do such because our DOACs carry a higher safety profile, or a better safety profile, I should say, in comparison to warfarin based on the landmark trials. All 5 of our agents now currently have reversals. Real quick review on that. Warfarin will utilize prothrombin complex concentrate, also known as Kcentra, in combination with vitamin K or phytondione. Dabigatran, we have Praxbind, and then for our factor 10A inhibitors, we can utilize either Indexanet alpha, which is only FDA approved for rivaroxaban and apixaban, or utilizing a weight-based or fixed dose of prothrombin complex concentrate, once again, also known as Kcentra. In terms of when we're going to see our direct oral anticoagulants used, so most commonly we're seeing AFib for stroke risk reduction, or for VTE treatment. This could be lifelong therapeutic anticoagulation or acutely after acute DVT or PE. We may also see patients who require either therapeutic or prophylactic doses of DOACs for VTE prevention, which could be related to hypercoagulable conditions such as cancer, or probably more common in your population, thrombophilias such as protein C, protein S deficiency, and then also seeing utilization for prosthetic heart valves. In regards to DOACs, we're not going to see these used for mechanical heart valves. It'll be primarily for bioprosthetic or tissue valves. In terms of where the current guidelines recommend DOACs, we can see that for the AHA, ACC, HRS 2019 guidelines, for patients who require anticoagulation secondary to AFib, there's a class 1 recommendation for all 5 agents, warfarin, as well as the 4 direct oral anticoagulants. However, you also see on the second bullet that there is a class 1 recommendation that recommends our DOACs over warfarin. The exception only being for patients who are considered to have valvular AFib, so those with moderate to severe mitral stenosis or with mechanical heart valves. This transition to us seeing more utilization and higher levels of evidence in support of DOACs also carries the same for VTE treatment. So there are 2 societies that have published guidelines that speak to utilizing a DOAC over warfarin. So that would be the American Society of Hematology, which has 2 different guidelines, one for the general population published in 2020, one for cancer-associated thrombosis, which was published in 2021. And as you can see, they suggest using direct oral anticoagulants over vitamin K antagonists for the general population. But for our cancer population, there's no recommendation in favor of dabigatran, the direct thrombin inhibitor, but they do recommend a factor Xa inhibitor over either Lovenox or warfarin. And as you can see, these same recommendations are echoed in the CHEST 2021 guidelines as well. In terms of making the decision to utilize a direct oral anticoagulant over warfarin, definitely a lot of factors to consider. These are just a few. And over time, we've grown to become more comfortable in using our direct oral anticoagulants, even in these subpopulations or specialty groups. Historically, the landmark trials excluded patients with significant renal and hepatic dysfunction. There weren't high numbers of patients with very old ages. Extremes of weight, so either low body weight or high body weights, which will focus the majority of this presentation on that. But over time, we've become more comfortable as there is more literature, mostly retrospective, highlighting that these agents may still be safe. So in regards to extremes of weight, we currently have, or let me not say currently, these are the old guidelines, the 2016 International Society of Thrombosis and Hemostasis. I first want to start here just to provide a baseline of kind of where we've come to where we are now. And as you can see, back in 2016, so once again highlighting that these are old recommendations, they suggest not to use DOACs in patients with BMIs over 40 or weights greater than 120 kilos. 100% just generating from the fact that there were very minimal patients who met these weight and BMI categories in those landmark clinical trials that brought the drugs to the market. The mean weights in these trials being roughly 84 kilos, and looking at just the subcategory of greater than 100 kilos, there was only 14 to 19% of patients included. They then go on to say, if you elect to utilize DOACs in patients with BMIs over 40 or weights greater than 120 kilos, then they suggest drawing drug-specific peak and trough levels. As I've mentioned, we really don't have any validated assays that can specifically speak to whether or not those peak or trough levels are truly achieving what is therapeutic levels. With that being said, it is still something that can be seen in clinical practice, and we'll also find that these recommendations have changed quite a bit from 2016 to now. If we take a deeper dive and look at those landmark trials, you can see here I have all 4 agents for the direct oral anticoagulants listed, our 3 factor Xa inhibitors, and then dabigatran, our direct thrombin inhibitor. With the study subdivided by VTE or AFib, you can see that for these extremes of weights, still a relatively small number of patients included. So BMIs greater than 30, roughly 30% in these select trials, BMIs greater than 35, anywhere from 12 to 13%. I've also went on ahead and included underweight patients. And then greater than 100 kilos, you can see that the range can be anywhere from 14% as high as 34.2%. So not a extremely small number of patients, but still not enough to where these experts felt comfortable in providing a firm recommendation that it was safe to utilize. That being said, with a number of different meta-analyses, over time, we've grown more comfortable in utilizing DOACs. So authors have highlighted similar outcomes for these small subset of patients, namely apixaban and rivaroxaban when compared to warfarin. In this meta-analysis of the landmark randomized controlled trials comparing DOACs to warfarin for treatment of VTEs, which included over 27,000 patients, of which greater than 5,000 were classified in overweight groups, there was no difference in the efficacy outcome of VTE recurrence or related deaths, as well as no difference in major or clinically relevant non-major bleeding. I also do want to draw your attention to these forest plots here at the bottom, namely looking at the Amplify trial, which is for apixaban, as well as the Einstein trials, which were for rivaroxaban, and that's for recurrent VT and VTA-related deaths, as well as in regards to major and clinically relevant non-major bleeding. You could see that it is really from these two trials, once again, apixaban and rivaroxaban, that kind of moves the curve over to the left, almost being in favor of direct oral anticoagulants over warfarin. Despite the lack of clinical evidence at the time, but considering the known efficacy and safety as well as convenience of DOACs in the non-obese population, use in obese patients has remained a common clinical practice, and several institutions have conducted large retrospective reviews that has further contributed to the growing body of evidence. In this particular retrospective trial conducted at a large U.S. hospital system, among the greater than 36,000 patients with non-valvular AFib that were reviewed, DOACs were utilized in approximately 50% of patients, regardless of their BMI. As you can see, there are 4 different BMI categories from underweight, BMI less than 18.5, what was considered normal weight, grade 1 and 2 obesity, and then grade 3 obesity of BMIs greater than or equal to 40. You can also see that DOACs demonstrated improved safety and efficacy across all BMI groups, and then there was no significant association with DOACs and risk of ischemic, hemorrhagic stroke, bleeding, myocardial infarction for these extreme of weight categories, which would include BMIs less than 18.5 or BMIs greater than or equal to 40. In this retrospective trial that compared DOACs to warfarin in greater than 19,000 patients, which included greater than 2,000 with BMIs greater than or equal to 35, after adjusting for baseline covariates, the odds of experiencing the primary outcome of stroke or systemic embolism for obese warfarin patients was 38.6% higher compared to the DOAC patients. Also of note, this study provides support for use in patients with weights greater than 150 kilos, which is kind of a standout feature in comparison to other trials, as this is quite often another extreme of weight group that is commonly excluded. So among these 208 patients, those receiving DOACs experienced the primary composite outcome of stroke and systemic embolism less often than patients receiving warfarin, and showed no significant differences in bleeding. And here are some additional observational studies that further highlight the lack of difference between our DOACs and warfarin in the morbidly obese population. These first 3 retrospective studies in the obese patients demonstrated no difference in VTE recurrence or in bleeding. I do want to point out how they defined obesity does vary a little bit. BMI is greater than 40 in this first trial In the second one, looking at just ICD-10 codes for morbid obesity, and they were only comparing rivaroxaban to warfarin. And then in the third trial, weights of 100 to 300 kilos constituted the overweight or obese population, and they looked at all DOACs versus warfarin. But once again, no difference in VTE recurrence or in rates of bleeding. And this last study included this is results from the prospective Dresden registry study comparing the use of DOACs for non-valvular AFib as well as VTE. And they were looking at all DOACs in patients over BMI greater than or equal to 30 versus BMI less than 30. And what they found was that there were similar rates of stroke, TIA, as well as VTE recurrence, as well as similar rates of major bleeding. So with all of this data, mostly from retrospective studies and meta-analyses, as well as some PK/PD data, the International Society of Thrombosis and Hemostasis updated those 2016 recommendations to now say, in the cases of treatment and primary prevention of VTE, they suggest standard doses of rivaroxaban or apixaban. So no recommendation in favor of dabigatran and edoxaban, but they do suggest standard doses of rivaroxaban and apixaban as being appropriate regardless of the patient's BMI and weight. I do want to first draw your attention to this limitation that there is minimal data for BMIs greater than 50, as well as weights greater than 150 kilos. They go on to suggest not to use dabigatran, edoxaban, or betrixaban for patients with this subcategory of VTE greater than 40 or weight greater than 120 kilos. They then go on to contradict their previous recommendation to suggest not to regularly follow peak or trough drug-specific DOAC levels because there's insufficient data to influence management. So now that we've answered the question regarding utilizing direct oral anticoagulants in our obese population, when these patients are arriving to the hospital or in preparation for their procedure, there needs to be a lot of discussion, both with the patient as well as their primary provider or their cardiologist or hematologist, whoever may be managing their anticoagulant, to really come up with a strategy for the pre-op window, as well as determining if the patient is appropriate for a bridge. And then determining what will be the best strategy for resuming the patient's anticoagulation. And we'll be referencing the American College of Chest Physician Guidelines, which was published in 2022. Determining when to hold anticoagulation, at least dictated by the chest guidelines, stems directly from the patient's bleeding risk, which here you can see is subdivided into high bleed risk category, at least what I have pictured, but then there's also moderate and low bleed risk defined by the International Society of Thrombosis and Hemostasis, only highlighting high bleed risk procedures as we're referencing bariatric procedures, which they don't particularly define, but with GI surgery, especially anastomosis, would definitely be included. So considering bariatric surgery being a high bleed risk procedure, the general strategy for oral anticoagulation will be interrupting 4 to 5 half-lives of the drug, and then considering resuming 2 to 3 days after the procedure has been performed. If we were to try to simplify those recommendations into a chart, and I understand this chart actually looks a bit busy, but this is adapted from the PAUSE trial's perioperative protocol. The PAUSE trial was a large multinational prospective randomized controlled trial, particularly looking at patients with AFib. They found a low rate of bleeding as well as thrombosis in patients that did not receive any bridging and also did not have any therapeutic DOAC monitoring conducted. The chest peri-op recommendations stem directly from the protocol pictured here. I'll try to acclimate your eyes to this. So first, just looking at the apixaban row, or I will first look at this left column. Apixaban, dabigatran, and rivaroxaban were the only 3 agents that were studied within the PAUSE trial. I've added warfarin here at the bottom just to have as a comparator. As you can see in the next column, they're subdivided further into high versus low bleed risk categories. And then you can see the DOAC interruption schedule. So if you see an arrow, that is when the patient is receiving therapy. The orange arrow is for high bleed risk procedures. The dark blue arrow is for low bleed risk procedures. And then you see this light blue arrow, this is just for dabigatran for patients who had creatinine clearances less than 50, as there is that firm dose adjustment that may need to be required, as well as the caveat that that agent likely will have prolonged effects with creatinine clearances less than 50. So if we're looking at just apixaban, for example, patients should be continued on their Eliquis up until 48 hours pre-op, after which the agent will be held, and then the consideration to resume should be roughly within 48 to 72 hours after the procedure has been conducted. In the case of warfarin, though, as comparison, you can see that this agent has to be held at least for 5 days, if not longer. Typically, there is the consideration to also check an INR prior to the procedure, just to ensure that the patient is no longer sitting within a therapeutic range. And then after which, because warfarin takes so long to enact its effects, the determination on when to resume it really falls, of course, to the surgeon, but within 24 to 48 hours is of consideration according to the CHEST guidelines. As discussed, bleeding risk is typically what we're looking at to determine our decision to hold and when to resume, but then comes the decision on whether or not bridging is necessary. Very quickly, we can state that for DOACs, because their kinetics is quite predictable with quick onsets and quick offsets, we can say quite confidently that bridging is almost entirely not necessary for our direct oral anticoagulants. However, in the event you do get a warfarin patient, there are certain subpopulations where bridging will be recommended. I will say, since the previous CHEST guidelines, as well as some previous AHA guidelines on bridging, these recommendations have changed quite a bit. Previously, we would see bridging recommended almost entirely for a majority of our mechanical heart valve patients. However, the recommendations now pretty much state that for all patients that are considered to be at a low or moderate risk of thrombosis, these patients no longer require bridging. Their recommendation to bridge is strictly for high thrombotic risk patients, which is further subdivided based on their indication. So not all mechanical heart valve patients will require a bridge, only those with certain specific types of valves. So caged ball or tilting disc valves, the location of the valve will also be important, as well as if they've had any other thrombotic conditions within the last 3 months. In regards to AFib, depending on how high their CHA2DS2-VASc score, that could place them at what's considered high thrombotic risk, in which case there should be consideration to bridge. And then in the case for VTE, depending on the time of when the DVT or PE occurred, there may be consideration to bridge, or if the patient falls into one of these severe thrombophilia subcategories. So to once again give you a very, very busy slide, but try to put all of the CHEST recommendations for peri-op use of anticoagulants into one particular chart, you can see that I have 3 main rows to highlight: our pre-op hold recommendations, our bridging recommendations, and then our post-op resumption of oral anticoagulant recommendations. For the general population, so really referring to low to moderate bleed risk patients. The pre-op hold rec for apixaban, rivaroxaban, edoxaban, and dabigatran is 1 to 2 days or 1 to 4 days. This 1 to 4 days, once again, is generated from the patient's renal function. So if they do have significant renal dysfunction, which for dabigatran is a creatinine clearance less than 50, then they would recommend 4 days versus 2 days if the patient had what would be considered normal renal function for that drug. For high bleed risk procedures across the board, though, our factor Xa inhibitors should be held at least 2 days prior to the procedure. I will also caveat that this may need to be extended depending on if the patient has poor renal function. The reason why there aren't any specific recommendations for these 3 agents in comparison to dabigatran is just because that's not how it was studied for the PAUSE trial. They actually excluded patients with creatinine clearances less than 25 for apixaban and creatinine clearance less than 30 for rivaroxaban. In regards to bridging, as mentioned, bridging is typically not going to be indicated for any of our direct oral anticoagulants. And then if a patient does present on warfarin, the only population that should receive bridging will be those that are considered to be at a high thromboembolic risk. In terms of the decision of when to resume postoperatively, if we're just focusing on high bleed risk procedures, and this I'm dividing from bariatrics because the recommendation is going to be slightly different, as we'll see in some other guidelines. 48 to 72 hours is considered to be a safe window post-operatively to consider resuming the direct oral anticoagulants. That being said, further delays, of course, would be required if hemostasis is not achieved, if there's a potential need for additional interventions, and then, of course, if the patient is unable to take PO, then they won't be able to take that oral anticoagulant. In the case for bariatrics, though, that 48 to 72-hour window still stands. However, they'll still want to avoid oral administration of anticoagulation. And that'll be where we'll kind of jump into our bariatric surgery types. So as of 2020, the most common procedures, bariatric procedures in the US were sleeve gastrectomy, 58.8%, followed by room-wide gastric bypass, 20.8%, then adjustable gastric banding. It actually dropped to 1.2%. From what I read from this 2022 ASMBS article, appeared to be related to effects of COVID-19, or at least that's kind of how the authors put it, where they saw this drastic drop in adjustable gastric banding compared to previous years. Then revisions actually were 11.1%. And then there are biliopancreatic diversions with duodenal switch, which was 1.8% of procedures performed. In terms of how bariatric surgeries will affect the oral pharmacokinetics of our drugs, so bariatric surgeries will vary in terms of effect on food and drug absorption, as well as metabolism. So bariatric surgeries will alter the absorption of drugs by disrupting or bypassing the absorptive surface of the stomach and proximal small intestine, reducing gastric volume, surface area, intestinal transit time, increasing gastric and intestinal luminal pH, which would alter the solubility of drugs that are relying on an acidic pH. These procedures can also alter drug metabolism and resorption by changing the distribution of cytochrome P450 enzymes and our P-glycoprotein transporters. Outside of the procedure-specific changes, the resulting lifestyle changes that follow bariatric procedures will also lead to alterations in drug pharmacokinetics, including caloric restrictions, weight loss, and the reduction of chronic inflammatory conditions that are typically associated with obesity. The location of drug absorption, its solubility, the importance of intestinal enzymes, and efflux pumps are all criteria that also determine the extent of absorption after bariatric surgery. So bringing back this chart, but with a little bit different information, we're going to really just be focusing on our 4 direct oral anticoagulants, but starting from the top. In regards to bioavailability, you can see there is a wide range from 3 to 7% with dabigatran to 80 to 100% with rivaroxaban. In terms of the site of absorption, all of our oral anticoagulants, including warfarin, are primarily absorbed in the stomach and the proximal small intestine. Dabigatran is absorbed in the stomach and the duodenum. Rivaroxaban is primarily absorbed in the stomach with gradual reduction in absorption as the drug passes through the intestine. Apixaban is absorbed in the proximal small intestine with limited gastric and colonic absorption. And then edoxaban is primarily absorbed in the proximal small intestine. In regards to food, some of these agents are heavily reliant on food in order to have adequate absorption. In the case of rivaroxaban and dabigatran, they may be especially impacted by procedures that resect or bypass the stomach, which could result in caloric restrictions and reduce gastric acid secretion. First, looking at dabigatran, so in relation to food, but also in relation to requiring an acidic environment, dabigatran is compounded in tartaric acid. So in order for the prodrug to be absorbed, it needs to be in an acidic environment. For the case of rivaroxaban, it is heavily reliant, at least the therapeutic doses of rivaroxaban, so 15 milligrams and 20 milligrams are considered therapeutic doses of rivaroxaban. Those doses have to be administered with food to ensure adequate bioavailability, which could either be reduced in the absence of food or increased in the presence of food by 39%. In regards to our CYP3A4 enzymes and P-glycoprotein transporters or efflux pumps, CYP3A4 is located along the entire small intestines with slightly increased expression from the duodenum to the middle section of the jejunum. So by bypassing the proximal segment of the GI tract, so that would include gastric bypass and biliopancreatic diversion with duodenal switch, it could result in a significant increase in oral bioavailability due to decreased metabolism. So that could be affected mostly in the case of our factor Xa inhibitors, rivaroxaban and apixaban. As you can see, 30 and 50% reliance on CYP3A4 for metabolism. On the opposite end, so conversely with P-glycoprotein, its concentrations are lowest in the duodenum, but highest in the distal ileum and colon. So for those same procedures, gastric bypass and biliopancreatic diversion with duodenal switch, it actually could lead to decreased drug absorption due to increased efflux of DOACs back into the gut lumen. So, considering these anticipated alterations in pharmacokinetics for our DOACs, there have been a handful of PK and retrospective studies that highlight the use of DOACs in the post-bariatric surgical population. Drawing your attention to this first trial published in 2022. This PK/PD study looked at AUC, so area under the curve, to give an idea of full drug absorption or full drug exposure, Cmax, which would be the peak of the drug, and then factor Xa activity. So what our factor Xa inhibitors will be working against. Looking after a single dose of apixaban 5 milligrams in healthy patients. So patients who otherwise have no indication to receive apixaban. And they were looking at pre versus post bariatric surgery for these three endpoints, with the post-bariatric surgery endpoints of 1, 6, and 12 months. What they found was that apixaban exposure increased from 0 to 1 month, returned to baseline at 6 months, and then decreased at 12 months. They found no significant change in peak effects from the pre to post-bariatric surgery periods. And then pre-dose factor Xa activity dropped significantly from 113% pre-op to 89.8% at 12 months. Conversely to that, 3-hour post-dose factor Xa activity levels was significantly lower at 1, 6, and 12 months post-op versus pre-op. What these authors said is that this effect appeared to be primarily the result of a decrease in factor Xa activity from bariatric surgery itself, and not a postoperative change in apixaban PK and PD parameters. So they concluded that the effect of either sleeve gastrectomy or Roux-en-Y gastric bypass on apixaban PK and PD parameters was minimal. Kind of along that same note, in this study conducted in 2018, very similar in fashion, looking at area under the curve, Cmax, but instead of looking at factor Xa activity, they looked at prothrombin fragments. They looked at single doses of rivaroxaban, 10 milligrams. We mentioned that 15 and 20 milligrams are therapeutic doses. So they were just looking at a prophylactic dose of rivaroxaban in otherwise healthy patients who did not require anticoagulation. And they also looked at pre versus post-bariatric surgery patients, but looking at 6 to 8 months post-op. They only included 12 patients, once again, just sleeve gastrectomy and gastric bypass. Their mean exposure to rivaroxaban in the post-op setting, they say, was comparable to those measured in the pre-op group, and that's for both sleeve gastrectomy and bypass. For the peak levels in the post-op setting for Roux-en-Y gastric bypass, they found that they were lower than the pre-op value, but in sleeve gastrectomy patients, they found that the peak levels were similar. Rivaroxaban also led to a decrease in these prothrombin fragments 1 and 2 in the postoperative setting, which correlated to rivaroxaban's effects in the pre-op setting, thus confirming their in vivo efficacy. So authors concluded that the significant weight loss and altered anatomy of Roux-en-Y gastric bypass and gastrectomy procedures do not appear to affect the pharmacokinetics and pharmacodynamics of prophylactic rivaroxaban. So growing evidence to suggest, at least from a PK/PD standpoint, that although there are these theorized alterations in absorption of apixaban and rivaroxaban, there's also this consideration that our actual clotting factor activity levels are also going to be reduced in the postoperative setting after having these bariatric procedures. So transitioning to patients who are actively on treatment or have indications to receive our direct oral anticoagulants. This is another PK study published in 2018, looking specifically at DOAC peak levels. They were looking at median time from surgery. So the median time of, they were looking at patients with a median time of surgery of 5 years, but ranged from 1 to 11 years. And they were comparing post-bariatric surgery versus non-bariatric surgery patients. A total of 36 patients with predominantly sleeve gastrectomy, a relatively even split almost with apixaban and rivaroxaban with 2 dabigatran patients. They found that all peak apixaban and dabigatran levels were within expected ranges. However, for the 7 patients who used rivaroxaban, there were 5 post-bariatric surgery patients who had peak rivaroxaban levels that were below expected compared to none in the control, which was statistically significant. Of those 5 patients, all 4 who underwent sleeve gastrectomy and 1 who had adjustable gastric banding were of the 5 who did not have those pre-peak rivaroxaban levels in comparison. With that being said, though, they had no reported hemorrhagic or thromboembolic events. In terms of this next trial, a retrospective chart review, looking at post-bariatric surgery versus general morbidly obese patients. They had a total of 102 patients, 51% being gastric bypass, 37.3% of sleeve gastrectomy. Only looking at apixaban and rivaroxaban, they found no difference in VTE recurrence or rates of composite major bleeding or clinically relevant non-major bleeding. And then similar results also found in this second retrospective match cohort study. This took a different approach. Instead of just looking at post bariatric surgery patients versus general morbidly obese patients, they also looked at DOACs versus warfarin in patients who were receiving oral anticoagulation for non-valvular AFib in the bariatric surgery group. So first, I guess, looking at bariatric surgery versus non-bariatric surgery patients, they found no difference in thromboembolic events, major bleeding, or mortality. When we then take just the bariatric surgery group and look at all oral anticoagulants that were received in the bariatric surgery group, comparing DOACs to warfarin, they found similar rates for the cohort in regards to embolism as well as bleeding. So utilizing the limited literature available, the International Society of Thrombosis and Hemostasis provided this summary of expected impacts of gastric banding, partial sleeve gastrectomy, and then Roux-en-Y gastric bypass. As you can see, they have it subdivided based on whether it's unlikely affected for the procedure or possibly reduced. And as you can see, the majority of our oral anticoagulants have this caveat that they are likely going to be reduced based on these procedures, except for apixaban in regards to gastric banding and then partial sleeve gastrectomy. So when it comes to where the guidelines currently stand in recommending for or against the use of direct oral anticoagulants for bariatric surgery, we talked about the American Society of Hematology guidelines earlier on in the presentation. They make a very general statement that for patients who have any condition that may influence medication absorption, highlighting bariatric surgery, that these patients are not optimal candidates for DOACs. However, looking at the International Society for Thrombosis and Hemostasis, once again, these were the updated 2021 guidelines. They suggest not to use DOACs, but they then go on to caveat to say for the acute setting after bariatric surgery, they suggest that initiating a parenteral anticoagulant in the early post-surgical phase would be most appropriate, and then there could be consideration to switch to an oral anticoagulant after at least 4 weeks of parenteral treatment, and they include both warfarin as well as our direct oral anticoagulants. They don't provide any strict recommendation as to which direct oral anticoagulant, but we'll get to some additional recommendations in a future slide. They do also suggest obtaining a direct trough level to check for drug absorption and bioavailability. So before in our morbidly obese population, they suggest not routinely doing so, but for bariatric surgery, they do recommend checking these levels if you do elect to utilize DOACs in this population. In terms of what levels they're referring to, because I've mentioned already, and y'all, I'm sure, may already be aware that We do not have a validated assay like INR, International Normalized Ratio for Warfarin, for any of our direct oral anticoagulants. We do have drug-specific assays for our factor Xa inhibitors. However, these are not validated tools to let us know whether or not the patient is actually within therapeutic range. When we are referring, or when these guidelines are referring to checking these levels, they're usually referring to referencing these levels to what's called on-therapy ranges. And these on-therapy ranges are just the drug levels that were achieved during the landmark clinical trials that brought each agent to the market, assuming that if we were able to obtain either similar or superior outcomes compared to warfarin, and the majority of patients achieve these therapeutic ranges, then we should assume that we would be able to achieve those same effects in the morbidly obese or post-bariatric surgery population. However, these are not validated therapeutic ranges for DOACs. Their use is widely debated, and most would consider not using these routinely, as there are several barriers, namely access, familiarity with obtaining and interpretation of the results. So the International Society of Thrombosis and Hemostasis, they recommend using these, but the results should still be interpreted cautiously. So now that I've tried to do my best to talk you away from that, let me tell you how you can use those levels in the event that you do decide that you want to still check those levels and place patients on DOACs. So this is just one particular approach that was published in an in-clinic article from the Journal of Thrombosis and Hemostasis. It's coming from McMaster University in Ontario, Canada. They stick still to the International Society for Thrombosis and Hemostasis guidelines in avoiding a oral anticoagulant for at least the first 4 weeks postoperatively. They abbreviate that period to say within 1 to 4 weeks, they consider switching a patient to a direct oral anticoagulant. At that time, they are only utilizing factor Xa inhibitors, so apixaban, rivaroxaban, or edoxaban. They then will check a drug-specific anti-10A activity level 3 to 5 days after initiating the drug. And the reason for 3 to 5 days is that's typically when these drugs are reaching steady state. After they receive that level, then they will utilize this flow chart to determine what's the next steps. So if that level comes back within range, then they'll continue the DOAC, document the discussion with the patient, and then offer to repeat the level in 6 months. And then typically after that 6-month period, unless there's a change in drug-to-drug interactions or any other significant change in outcomes for the patient, then there's no additional monitoring required. However, in the event that that DOAC level is low, their first question is going to be, was the patient adherent on therapy? Were they getting the appropriate dose? Was the timing of that level appropriate? Was the patient actually at steady state? Were they taking food in the case of rivaroxaban? And then depending if that answer to all those questions are that the patient was doing what they were supposed to do and the level was drawn appropriately, then they'll consider switching to a DOAC or potentially just switching to warfarin. In the case that the level is high, then they'll look at what bleeding risks does the patient carry? Are there any modifiable risk factors that should be considered? Is the patient on an antiplatelet agent that they no longer need to be on? Are they on any other drugs that may predispose them to bleeding? Are there any drug interactions that could increase the drug levels of our direct oral anticoagulants? And then once again, still going back to shared decision-making with the patient, they'll either elect to continue therapy or consider switching. So to kind of summarize what we've covered today, apixaban and rivaroxaban, so just those two factor Xa inhibitors were recommended as appropriate options for non-valvular AFib and VTE, regardless of weight and BMI. I once again do want to caveat that there's minimal data for patients with weights greater than 150 kilos or BMIs greater than 50. So we still have to utilize this recommendation cautiously for this subgroup. We also still need to consider certain patient-specific factors. So renal and hepatic function that we previously mentioned, and then any significant drug-to-drug interactions. In regards to perioperative strategies for managing oral anticoagulants, it definitely would be best to involve the outpatient, that particular patient's outpatient provider who's managing that anticoagulant, whether that's cardiology, hemonc, or a family medicine or internal medicine doctor, just to have them weigh in on where the patient stands in terms of thrombotic risk and help with bridging. Now, granted, that may not be the case or necessary for DOACs, but particularly the case for warfarin. In the event that there is a need for bridging, then planning for parenteral therapy, looking in the postoperative setting, particularly for our bariatric cases, to determining what would be the most appropriate parenteral agent to place them on for that initial 1 to 4 weeks. And then looking to switch them either to warfarin or potentially to a different direct oral anticoagulant. Considering the fact that there's still very limited literature for DOACs in the post-bariatric population, warfarin still remains the preferred agent. It is definitely still a hassle. I kind of glossed over how compliance can sometimes be a factor in deciding DOACs versus warfarin. In the case of warfarin, the issue with compliance is it just comes with a lot. Patients have to get frequent INR checks. It can start as weekly, it can go to being several months away, but patients have to be very consistent with their vitamin K intake, so diet can be definitely a huge issue. Drug-to-drug interactions, there are so many, but once again, the benefit of having a therapeutic INR to go off of and adjust the dose is beneficial. However, with DOACs, in terms of compliance, it seems nicer, it's easier on the patient. They're either taking it once a day or twice a day, no monitoring required. But the concern is if there's an issue with compliance, patient misses 1 dose, they're very much so predisposed to a thrombotic event. So definitely have to weigh the risk benefits there when electing to choose a direct oral anticoagulant, particularly in a patient where there is limited evidence in support of it. In the event, though, that we are utilizing DOACs, the recommendation still stands, according to the International Society for Thrombosis and Hemostasis, to delay at least until 4 weeks postoperative and to be in consultation with the appropriate providers to consider monitoring DOAC peak and or trough levels if it is deemed appropriate to reinitiate those therapies. And here are my references, and I will be happy to take any questions or comments. Thank you all very much for your time.
Gosh, thank you, Patrick. What a wonderful presentation. Yeah, so if anyone has any questions, you can put those in the chat, and we can go from there. And I think you will see also how you can claim the CEU. There's a link for that, and then there will be a follow-up email as well. Are you able to see the chat too, Patrick?
I can, and I see a question from Kelsey. So if we are doing malabsorptive procedures on patients that have to be on vitamin A, E, and K, if DOACs aren't recommended in these patients, but vitamin K is an antagonist, so is the DOAC recommended at this time or warfarin dose more closely monitored? What would be recommended is to just maintain the patient on warfarin, but closely monitoring them. So knowing that we are going to be increasing their vitamin K, there'll be that expectation that their warfarin dose is likely to be increased. I also, in coming forward with this presentation, found a lot of literature showing that in the postoperative setting, there are wide variability in warfarin dosing. So immediate post-op, they find that patients' warfarin dose requirements drop substantially. And then over the next 3 to 6 months will increase dramatically back to what the patient's pre-op warfarin dose was. Me not having as much bariatric experience as I would like to speak to all those changes that occur. I feel like these patients that end up being on those like fat-soluble vitamins, ADEC, definitely could be an explanation for that. But yes, to finalize that recommendation, it will typically be to maintain warfarin just because you do have that capability to monitor INR and adjust the dose accordingly.
Thank you. Any other questions, comments? I've seen some great presentation. Thank you. I think that question maybe went to just you. Oh, here's another one that I can see. Do you see that?
I can see it. What are your thoughts on Roux-en-Y, duodenal switch, developing ulcers with DOACs? Oof. Well, I would imagine that if the patient ends up developing a significant ulcer, and I'm assuming this isn't a patient that is presenting with an acute GI bleed, in the event that they are, then of course we're going to be holding all oral anticoagulants and probably referring to your expertise or to GI to determine when it may or may not be appropriate to potentially reintroduce oral anticoagulants. As we kind of glossed over, the landmark trials have highlighted that our direct oral anticoagulants have a a safer bleeding risk profile if we're looking at them globally compared to warfarin. There are certain direct oral anticoagulants, particularly rivaroxaban and dabigatran, that were actually associated with a higher risk of GI bleeding, but a lower risk overall of bleeding. So I would take that into consideration in the event that there's ulcers. I'd probably avoid those two DOACs. I think it could be considered to utilize apixaban, but noting that for Roux-en-Y and duodenal switch, there is that perceived expectation that we're already going to have a significant drop in absorption of apixaban. It may still be worthwhile to have the patient on warfarin or particularly just on Lovenox, as Lovenox we know works just as predictably as we can say for DOACs. We stop it, it should be cleared out of the body in roughly 24 to 48 hours completely. And then we also have an agent to reverse that if need be. For our warfarin, we know that's going to last a bit longer. Although we do have reversal agents, in the need to have to stop quickly and then make the decision to reverse or not to reverse, that'll be a little bit easier. So I would say in that type of patient, I would elect to initially start the patient on Lovenox. You can check anti-10A levels actually for Lovenox to make us feel a little bit better about what dosing the patient's receiving. And then after which I probably would lean towards placing the patient on warfarin, more so just because I still have that capability of monitoring. And then I would elect to have close monitoring even after the patient has achieved therapeutic INRs after 2 checks.
Thank you. There was another question asking if you would be willing to share your PowerPoint.
Absolutely.
And
absolutely.
If you can just send that to me and I'll get that to the ASMBS staff to disperse.
For sure. I have no problems with that as well. Well, I do see another question from Heather. What are your thoughts on DOACs restarting post-SATI that were previously on for AFib? Refresh my memory on SATI.
That's another, and we do not do the SATI duodenal switch at our facility, so
okay.
Probably Patrick nor I are very well versed on speaking to that specifically. I don't know if there are other committee members that may, or we can certainly take that question back and
send back out an answer to you. Yeah. In my search in preparing this presentation, I didn't come across any specific recommendation for this procedure. So yeah, I'd have to get back to you.
Yeah, I'll write it down.
Excellent.
Yeah.
But yes, to say that I would love to hear all of your experience. If you already have an approach to using DOACs in the postoperative setting, our approach that we've established here is quite often we're going to get hematology and oncology involved to kind of help with deciding if it's best to switch the patient to warfarin. Usually that decision is really just going to fall to the patient as well. The good thing about the bariatric population, y'all have already done a great job of selecting patients who are going to ideally be very successful because they are committed to all of the constraints that are required prior to even being able to be appropriate for a bariatric procedure. So typically those patients end up being great warfarin patients. They're going to be compliant because they are already set the tone of being compliant with all the requirements that are needed for bariatric surgery.
And then I don't know if you saw, there's another question. Is there any degree of consensus for duration of post-op prophylaxis in high-risk patients? And then question mark, 4 weeks, question mark.
That's a great question. This is another one that I would want to have to get back to you on. So in speaking about, just to make sure I'm getting the question right, this is for somebody who otherwise does not have an indication for therapeutic anticoagulation, and it's solely just to see how long patients should be on peri-op prophylaxis. I would have to come back to you on that one, but yeah, I'm curious to hear what other people's strategies are.
Kind of our protocol is for a patient who has a BMI greater than 50, they are on Lovenox 40 milligrams daily for 28 days. For patients with a BMI of 60, they're on Lovenox 30 milligrams twice a day for 28 days. It's kind of our protocol. But yeah, I think it's not a huge consensus. I know there's not really a consensus that I'm aware of. It's people kind of,
Yeah, the dosing schemes, we actually are just now in a transition in regards to system. I guess I should be careful. I don't want to say system ownership, but we are having a transition in terms of our current EMR, and we are adopting certain dosing regimens, and DVT prophylaxis has definitely come up, particularly with bariatrics. As Jenny mentioned, there are so many trials. The literature is quite variable. So with all that heterogeneity, it's very difficult for me to make a firm recommendation, at least on dosing. In terms of duration, though, like I said, I would want to get back to you. But yeah, glad to hear the 28 days in terms of our recommendation, but curious if anyone else has a different recommendation or dosing strategy.
Aura is also a member of our committee. She's out in Oregon, and she just said they do 40 milligrams twice a day for 2 weeks.
2 weeks.
Then there's Catherine, the Caprini scoring, BMI greater than 40, Lovenox 40 twice a day, greater than 30, Lovenox 30. So we don't even treat for anything less than 50.
Yeah, Jenny, I was gonna
40 BID for 2 weeks.
The current recommendations that are at least built out in Epic now speak for BMIs greater than 40 for these patients to get 40 twice a day, at least how it's built in BSMH Epic. And then for BMIs greater than 50, then they recommend 60 twice a day of Lovenox. Yeah.
So I think Dr. Mitchell, our physician, is I think on the call. So the new medical record we just went to is Epic. So we're having some transitions with that, but
for sure.
So yeah, it looks like a lot of different, I say different, but yeah, 40 for 30 days, Cleveland Clinic score. So I know we are at right over time. It's 8:32, and just being respectful of Patrick and his time, getting back home, since I know you had to come to the hospital to do the presentation. And so we can begin our networking session. I will kind of respectfully kind of end our Q&A. And just again, thank you, Patrick. This was a fabulous presentation, and we might be knocking at your door again.
That's awesome.
We plan out these webinars for the next, couple of months and years. So,
excellent.
If you do have any further questions that we didn't get answered tonight, I can put my email in here. And then if anyone wants to email me, I am happy to get those questions answered.
Right. Well, thank y'all very much for your time and attention. This was awesome, and definitely appreciate the dialogue. And I'll be sure to send you the slides, Jenny, so those can get circulated out to everyone.
Okay, that sounds great. Thank you again, and have a good evening, Patrick.
Absolutely. Thank y'all.
All right, I'll see you next Thursday.
Yes,
at our
ma'am.
meeting.
Bye, everybody.
Good night.